I've introduced everybody. Welcome to unRemarkable Labs. I think we can go ahead and get started with Mahmood's case whenever you're ready.
We'll dive right into it. Again, I'm Mahmood. I'm a second-year internal medicine resident at UAB, and I'll be presenting the case. So we have a 52-year-old female who presents to the hospital with a primary complaint of jaundice.
You guys always give me a good jaundice case. I like it.
So what questions would you guys want to know next? So you hear about jaundice, you see jaundice. What do you want to know? And you can put it in the chat, you can unmute.
How long it's been going on?
Yeah, so she said about 3 days ago, she started noticing her skin turning yellow, and it just progressively got worse and worse over the past 3 days.
Got a bunch of questions popping up in the chat. Any recent travel?
She hasn't traveled anywhere. She's never been jaundiced before. As far as any new medications, she said that she had a urinary tract infection recently and went to her OBGYN who had prescribed her an antibiotic, which she wasn't sure what it was.
Has she ever had jaundice before? Did you answer that already?
She has not ever had jaundice before.
Okay. Not exactly sure what we're getting at with the pet rat, but I'd be curious to hear more about that.
No, there's no pet rat. As far as changes in stool or urine, she states that previously she had kind of a year-long history of loose stools after she eat, which has now been resolved. She said she had a sigmoidoscopy with biopsies at that time, which were negative and resolved on their own. As far as urine, no changes in color of urine, no, her dysuria resolved, no changes in frequency or duration or caliber of urine. For abdominal pain, she does have this vague right upper quadrant abdominal pain that is worse with palpation. She hasn't been able to attribute the pain to PO intake. It just kind of is there on and off throughout the day. Okay, and then, so no itching. And then any over-the-counter supplements from GNC. No GNC supplements. She does take some vitamins, biotin, B12, and vitamin D.
These are all great questions. Any other constitutional symptoms, fevers, night sweats, weight loss?
No fevers or night sweats. She said she has been feeling more fatigued recently. And no weight loss from what she has noticed in the past 3 days or previously. And no melena or hematochezia. She hasn't noticed any blood. Her bowel movements have been brown in color.
Yeah, that's great. Did anyone do a fit test? Love it.
No.
Yeah, I think you guys asked all of the good questions. You know, I think we've talked about this on our other episodes, but anytime you're interviewing someone with symptoms, you know, you always want to think about what your differential is, and that helps drive what questions you ask. So I think you guys did a lot of that. I think a lot of the kind of abdominal pain and hematochezia and those type of questions were probably aimed at thinking about UC and PSC as a common combination that we see together. I like, you know, we had that lymphoma case the first time that had cholestatic, vanishing bile duct syndrome with cholestasis the first time around. So I like that you're thinking about constitutional symptoms that would go along with lymphoma. Certainly medications are a very common cause of jaundice. So I like that you were specifically asking about things like over-the-counter supplements, because patients often forget to mention those. It's also helpful when you're thinking about the antibiotics and over-the-counter supplements to ask them, to go back in their mind about 6 to 8 weeks. Because, a lot of times by the time patients present with jaundice, the bilirubin can be quite high, and that takes several weeks to develop. So often it is a medication that they've actually taken, 2 or even 3 months prior to presentation. And then, sometimes I specifically just bring up names of things because that may trigger their memory. So things specifically like green tea extract, Garcinia cambogia, some of these weight loss supplements, Augmentin, Macrobid, these are sort of Bactrim. These are common things we think about. So sometimes I'll just name things specifically and see if it rings a bell with the patient. I think other things I would potentially ask about would be a history of autoimmune disease, either in herself or in her family, thinking about things like autoimmune hepatitis. I know we haven't quite gotten there just yet, but.
Yeah, but to answer your question, no personal or family history of autoimmune disease.
Good. And then, certainly with painless jaundice, of course, thinking about, pancreatic cancer. I think that was one of the questions about pain and constitutional symptoms. So certainly cholangiocarcinoma, pancreatic cancer, lymphoma, these are all good things to think about. Any other questions you guys can think about? Nope.
Okay.
All right. I'll move on to the past medical history.
Yep. So past medical history, she has a history of asthma, which she takes as needed albuterol inhaler. She also has a history of GERD, which she is on some Nexium. And she has a history of pinealoma. She's had multiple VP, she has a VP shunt and she's had multiple revisions. The most recent revision was about 5 months ago.
And we didn't ask you about alcohol intake, but we should have, because alcoholic hepatitis can certainly cause jaundice.
Yeah. She has not had any recent alcohol intake. The last time she drank anything was in 2005.
Okay.
And I guess I can finish the rest of the social. Doesn't smoke and no drug use. And as far as any other medications, that is all apart from, I had mentioned in the HPI that antibiotics she had been given. And yeah, and then no contributory family history. And she has had a cholecystectomy in the past. STIs. No history of STIs.
Yeah, we had that syphilis case a while ago, so that was a great question to ask. Certainly other causes of jaundice, then we think about pregnancy causes as well, but this patient seems a little bit outside of that age range. To answer your question, the syphilis case was jaundice with pretty elevated liver test. I think enzymes were over 1,000. All right. Does anyone have any other questions before we go to the physical exam?
I think one thing to keep in mind, I know we have Dr. Gray here and she's a hepatologist, so everybody's focusing in on the liver, but just thinking about jaundice, don't forget about the indirect causes. So hemolytic processes, look for rashes, look for causes of bruising, bleeding, and things like that. You can also have an elevated INR with liver failure. So then you can end up with some similar issues, but always think about the indirect causes as well, because that can cause jaundice.
Yeah, great point. Yeah, and we didn't really talk about viral hepatitis type things, but she wasn't having fevers, but certainly those are other things to think about. All right, tell us what she looked like.
All right. So vital signs, she was afebrile 98.5, heart rate of 78, blood pressure of 99/64, satting 95% on room air. Overall, she looked no acute distress, was actually walking around the room, and really not having any big complaints. On her HENT exam, she did have some scleral icterus, but overall, no other pertinent findings there. Cardiovascular exam was also overall normal, normal rate, regular rhythm. She didn't have any lower extremity edema and no overt JVD either. Her lungs were clear to auscultation bilaterally. On her GI exam, she had a soft abdomen, maybe some mild tenderness to the right upper quadrant, but nothing, not significant, and no overt hepatosplenomegaly either. Skin was diffusely jaundiced, and on her MSK exam, she had normal range of motion. She was ANO ×4, cooperative and pleasant overall.
Good. I feel like for a lot of these cases of jaundice, the physical exam tends to not give you a whole lot of information.
Yeah.
All about the numbers, I agree.
And Dr. Gray, just because we've talked about it before, and I know it wasn't mentioned in this case, but how doesn't hepatomegaly help you?
Yeah, hepatomegaly can definitely help. I think certainly infiltrative diseases, you think about hepatomegaly, so like infiltrative lymphoma, alcoholic hepatitis causes hepatomegaly. So certainly there are differentials that would be more likely to give you hepatomegaly than others. But specifically infiltrative diseases is what we think about most.
Okay.
All right. Should we just go on to the labs? Anyone have any other questions?
Yeah, show us the numbers.
Okay. We'll start with the BNP. So the sodium was 133, potassium of 4.4, chloride of 102, and bicarb of 17. She had a BUN of 12 and a creatinine of 1.1 and a glucose of 122. As far as her LFTs, so she had a AST of 1080, an ALT of 867, and then an alk phos of 182. As far as her Billy when she came in was 16.5. That's the total, with a direct of 9.3 and an indirect of 7.2. And on her CBC, her white blood cell count was 4.11, hemoglobin of 12.1, hematocrit of 36, and platelets of 314. I can also give you the albumin, wherever I wrote it down. Albumin was 2.4. And
how about an INR?
The INR was 1.8.
So how do these labs help you guys? Does this help you rule things in, rule things out? What are you thinking after seeing these labs?
I can talk since no one's talking. I will have to pull up the exact up-to-date list, but off the top of my head, there's only like, I think maybe 5 or 6 causes of usually when your AST and ALT are in the thousands. So I think of shock liver, alcoholic hepatitis, or really, I guess any of like Hep A, Hep B, Hep C, like acutely.
And you want to start kind of making our differential diagnosis there kind of as you're talking, because I think these are all
perfect.
All awesome points that you're making. Sorry to make you talk in.
No, that's okay. I'll let someone else talk.
No, you were saying all kinds of good stuff. But yeah, I think certainly thinking about what can cause the aminotransferases to be that high, like that's a great place to start. So you said viral hepatitis. So I like that. So that can be Hep A, B, C, you know, certainly less common, CMV, EBV, HSV. So alcoholic hepatitis actually very uncommon. Usually you don't see AST or ALT above 400, sort of the maximum that we think about with alcoholic hepatitis. But ischemic hepatitis, like you said, shock liver, so vascular things. What other vascular things could you think about besides just ischemia?
Like a clot, like portal vein thrombosis or something.
Or Budd-Chiari. Yeah, Budd-Chiari, acute. What other things do you think about when you see aminotransferases this high?
Some kinds of DILI. I'm not sure specifically.
Yeah, drugs and toxins, just as a broad category. I mean, I think most commonly we think about Tylenol, but certainly others can as well.
Someone's asking about fatty liver in the chat or iron overload.
Yeah, those are really both more chronic liver diseases that we'll see kind of mild to moderately elevated liver tests. I would say, over 200 would be uncommon for those. Yeah, portal vein thrombus, I've never seen that cause jaundice like this, so probably more outflow from Budd-Chiari would be more common. What else can you think about that can cause? There's a few other things. Yep. Wilson's, somebody just got that one in the chat. Wilson's can definitely cause very high liver test. And then, yep, it looks like Travis, you got it. Autoimmune, exactly. So autoimmune hepatitis would be another common cause that could cause this pattern of liver test elevation. So that's great. Yeah, great. Yeah, those are the big ones. So you guys did a great job with that.
I have a question for you, Megan. The albumin being low and the INR being high, does that suggest that this is a liver disease that's been going on for a period of time? Because this looks more like medical cirrhosis.
Well, I guess I would say not necessarily, because, certainly in acute liver failure, we get coagulopathy, and we know that albumin can be, low as an acute, sort of a negative acute phase reactant, I guess. So I would just say when your liver is really sick, even acutely, you can see these types of changes. And so I guess we didn't specifically, okay, I guess we did say her neurologic exam was normal. That was reassuring.
Does anyone know why Dr. Gray's worried about her neurologic exam after thinking about the INR? Encephalopathy, right?
Absolutely. Yeah, so when we think about acute liver failure, we think about, onset of jaundice within the last 8 weeks, encephalopathy, coagulopathy. And so certainly she has 2 of those. So she could be someone who's progressing towards acute liver failure, but looks like right at this moment, she's not meeting the criteria. So what testing do you think would be helpful to do next, knowing kind of what your differential is? Somebody said imaging. I like ultrasounds. That's great. Probably some serologic things as well that would be helpful, kind of simultaneously. Mamu, do you want to go ahead and give us the ultrasound results?
Yeah, so ultrasound was overall not too revealing. With Doppler was overall unremarkable. No stones or obstruction there. And as far as the liver, it did not appear cirrhotic or no steatosis either on the ultrasound.
So does that help you guys take anything off of your list? You guys are so quiet. You're just talking in the chat. But yeah, I think having a normal ultrasound is definitely helpful. So things like Budd-Chiari, you should see, hepatomegaly, ascites. So I think the ultrasound helps us rule that out. Very commonly, drug-induced liver injury, viral hepatitis, autoimmune hepatitis, these things, shock liver, all these things generally have a normal ultrasound. So didn't help us rule those out just yet.
Would you do any imaging, like an MRCP or something to look more at the biliary tree? Because obviously, sending off ANA and some of these other panels are going to take time. Someone comes in and gets admitted and they're there, and you kind of you're waiting on. I mean, I guess hepatitis panel comes back pretty quickly, but some of the other labs, might take more than a day to return. But if the ultrasound is negative, do you do any more imaging either with CT scan or MRI?
Yeah, certainly, I think the things that tend to be the most helpful in these patients in an ideal situation, non-invasive to most invasive, right? So labs first, but you're right, certainly some of the things take a while to come back, but I would say ANA, viral hepatitis panel, ceruloplasmin, those things typically come back fairly quickly. And then if so far you're not finding anything that's positive, then imaging such as MRCP can be very helpful to look at the biliary tree, especially, if you're looking for things like PSC or cholangiocarcinoma, things that would be directly involving the bile ducts. And then, liver biopsy sort of along that same spectrum. So sort of least invasive to most invasive, but those are the things on the table whenever we see a patient like this.
Do you take into consideration the alkaline phosphatase in that situation? So this is a normal alkaline phosphatase. If it was elevated, I would think we'd be really concerned about the biliary tree, but that being totally normal seems like this is more hepatocellular and intrahepatic rather than extrahepatic.
I completely agree with that. Yeah, when we see patients that are jaundice related to infiltrative malignancy or cholangiocarcinoma, pancreatic head mass, these patients, of course, will have an elevated alkaline phosphatase because their biliary tree isn't draining properly. So, and of course, that doesn't rule out, we still have several things on the list, but I do agree with you that biliary tract disease is definitely lower on the differential with a normal alk phos. So I think we need some additional labs. Did we ask her if she had taken Tylenol? I don't remember if we'd asked her that.
So she last took Tylenol earlier this month. I think she's only like one tablet, but hasn't taken any recent Tylenol.
Okay.
Now she was on an antibiotic. If she gets admitted to your service, if you could possibly find out what that antibiotic is, because you mentioned a number of antibiotics that could induce this.
Correct. Yeah, that's why I kind of just have a running list in my head and I try to just go through it with patients. The common antibiotics that we think about, especially that would have potentially been used for a UTI, macrobid, Bactrim, those are two very common causes of drug-induced liver injury. Augmentin is also a very common cause of drug-induced injury, maybe not used for a UTI necessarily, but yeah, sometimes if you can just name the antibiotic, the patient's like, oh yeah, that was it. That sounds right. So
I presented a case on CP Solvers today to Stefan Zavin. It was a drug-induced liver injury from atovaquone.
Okay. Yeah, so many different medications can cause drug-induced liver injury. You all probably know about the website LiverTox. But LiverTox is a really great resource where you can look up pretty much almost any prescription medication. And they do a great job at updating it too as newer medications come out. But it gives you sort of the mechanism of hepatotoxicity, if there is one, how likely it is that drug has caused any hepatotoxicity in the past. And then it'll actually give you some of the cases with liver tests and the pattern of elevation and when they rose and how long it took them to get better. And and those kind of things. So it's a extremely helpful resource, especially if the patient has a fairly minimal medication list and has only had 1 or 2 new things. It can be really, really helpful to look those up and see if other patients have had that before with that medication. All right, well, I would love to see some labs. So could we have a viral hepatitis panel, please?
Yeah, so the viral hepatitis panel was overall unremarkable. Just everything was within normal limits, not positive for anything, negative for Hep C, vaccinated for Hep B, and negative for Hep A.
Okay, and what testing, to test for hepatitis A and B, which 2 tests would be or 3, I guess, would be the most helpful that you guys would want to send?
Hep A IgM, Hep A IgM,
Perfect.
hepatitis B, surface antigen and antibody, hepatitis B core antibody, and hepatitis C antibody.
Yeah, that's great. Just hepatitis C very rarely presents acutely like this. So that's definitely lower on the differential, but yes, that's the correct evaluation. So good job.
And then I can go ahead and say that other viruses that were tested for HIV, CMV, HSV, and EBV were all also negative.
Okay. What other tests would you guys like to ask for, especially referencing our differential? Yeah, ANA, I would like that.
Okay, so we did check an alpha-1 antitrypsin, which was normal at 125, and then the ANA came back positive with a titer of 1 to 160 and a homogeneous pattern. The AMA was negative, and the anti-smooth muscle was also positive at a titer of 1 to 40.
So what do you guys think about that? I guess before you ask for more antibody levels, why don't you tell me what you think about the ones we have currently? Yeah, certainly raises suspicion for autoimmune hepatitis, absolutely. So, I would consider both of those to be kind of low titer positivity. So those can be positive in things that end up not being autoimmune hepatitis, but certainly ANA and anti-smooth muscle are the tests that we look at for autoimmune hepatitis. So I definitely think it's at least a little bit higher on your differential now. Other things that can be really helpful for autoimmune hepatitis is a total immunoglobulin G level, so total IgG. It's very uncommon to see someone with a acute autoimmune hepatitis flare with a normal IgG. So that usually comes back actually quicker than the antibody levels. So that can be helpful too. Did you guys happen to get an IgG for this patient?
We did. It was elevated at 4,762.
So that's incredibly high, right? 1,500 is kind of the upper limit of normal. So that is extremely high. It almost makes you worried that potentially other things could be going on. So what do you feel like you have all of your other differentials ruled out? What about Wilson's? What would you want to check for that?
Natasha's giving you a clue. Yeah, there you go.
Yeah, there we go. Sorry, I keep forgetting to look at the chat. Yeah, ceruloplasmin, that's great.
Yes, we checked that. It was a little bit low at 19.2.
Yeah, I agree with the comments. Yeah, she's definitely old to have a first presentation for Wilson. So yeah, I think 20 is like the lower limit of normal. So 19.2, I wouldn't necessarily put a whole lot of stock in. So yeah, Dr. Centaur, I think it asked about liver biopsy. So definitely, to confirm the diagnosis of autoimmune hepatitis, liver biopsy is necessary. So at this time, I would say our highest on our differential would be autoimmune hepatitis. And so biopsy seems like that would be the right next step. We do also have to think about the fact that sometimes antibiotics can produce a drug-induced autoimmune hepatitis. Similar to, what you would see in like a DRESS kind of syndrome. You don't necessarily have to have all of the DRESS symptoms to have drug-induced autoimmune hepatitis. We see that also with some of the seizure medications can commonly provoke that. And, I guess the importance of knowing whether or not it's drug-induced autoimmune hepatitis versus regular autoimmune hepatitis really is sort of in long-term management. Your short-term management would be the same, and really your liver biopsy would look the same. And so initially, but long-term down the road, you may be able to wean that patient off of treatment if it's drug-induced, and they would do just fine. So does
Is there
anybody
any way that you can tell that early on, or is it just kind of you follow them up in clinic and trial them and try to wean them off, and if you can't, their enzymes go back up, then you know it's autoimmune in and of itself and not drug induced?
Yeah, I think if they have one of the more commonly reported medications that can cause drug-induced autoimmune hepatitis, that would really be kind of your only suspicion. In terms of labs and biopsy, it's going to look exactly the same. But yeah, generally what I'll do is wean someone off steroids just as I would do with autoimmune hepatitis, but instead of starting azathioprine or Cellcept as I'm weaning off of steroids, I wouldn't start anything. And then once they're completely off of steroids, I generally get labs on a monthly basis just to make sure that they're not going to start flaring up again. And usually if it's drug induced, then they won't. All right, guys, was there any other, I guess just because of the last case we had, I'm going to just ask you about an RPR or treponema antibody.
Treponema antibody was negative.
Okay, all right. Does anyone want any other testing before we get a liver biopsy?
One other quick question. You said that the liver biopsy is always needed in autoimmune hepatitis. Why is that? Because a lot of the liver diseases, I know it's not, unless you're concerned that you can't tell which one it is.
Yeah, so yeah, diagnostic criteria for different liver diseases, of course, is different. But autoimmune hepatitis, I think there's just so many different things that can cause a positive ANA, and you can get false positive anti-smooth muscle antibodies, not as commonly as ANA, but it certainly does happen. So there's some cross-reactivity with multiple other things like viral hepatitis, et cetera. So seeing those classic findings on a liver biopsy, which would be things like, this lymphoplasmacytic infiltrate in the portal tracts and interface hepatitis, where the inflammation is kind of spilling out of the portal tracts into the lobules of the liver. Those are really classic findings that, you only see with autoimmune hepatitis. And especially, I think if you're going to be committing somebody to lifelong treatment, which is what we do when we diagnose someone with autoimmune hepatitis, then it's really important that you have the right diagnosis. Other things that can be helpful in liver biopsy too is just to stage their fibrosis, and help you see how much scarring and damage has been done. Anybody want to get a biopsy?
Let's do it.
All right. So I'll kind of explain what exactly happened. So
Okay, sure.
Dr. Gray actually, got this spot on. So the patient was admitted, and we were able to find out from records that her antibiotic she was started on was macrobid, and there was a concern for a DILI. Initially, she had just been sitting there waiting for a liver biopsy, but her T-bili kept uptrending, her LFTs were improving, her INR actually was uptrending as well. And then her IgG came back first elevated, and there was a concern for autoimmune hepatitis. So She started on some steroids and started improving. We did get a liver biopsy, which came back with marked plasma cell rich interface and lobular activity in areas of confluent necrosis. The pathologist basically said that the features are consistent with an immune-mediated autoimmune hepatitis, but that the temporal association with macrobid, as well as the clinical symptoms were concerning for a drug-induced autoimmune hepatitis-like syndrome. So that was the final diagnosis. She started improving on the steroids and was actually seen at 2 follow-up clinic visits where her LFTs have now normalized 2 months later. She's actually no longer on steroids. Her INR has also normalized, as well as her Billy.
Yeah, these are great cases, especially when you can identify the culprit agent. So macrobid is a common cause of drug-induced liver injury. And you know, the nice thing about these cases too is that once the patient's liver tests go back to normal, I mean, just to be on the safe side, I would probably monitor them for several months, but more likely than not, they're going to do just fine and they're not going to need any additional medications or immunosuppression or anything like that. And so it's, you know, a short course of steroids is curative, which is great. But macrobid can be a nasty drug. I actually had a patient referred to me with elevated liver tests that we ended up diagnosing autoimmune hepatitis, and she had been on macrobid as a suppression agent for recurrent UTIs for quite a long time. And she actually also had interstitial lung disease, which they felt like was related to macrobid as well. So even we took her off macrobid, but despite that, she's actually had progressive ILD, and from a liver standpoint has done okay, but her lung disease has continued to progress despite coming off of it. So, what questions do you have about the case?
Do you, when you do steroids because of liver metabolism, do you usually use prednisolone or do you use prednisone?
Yeah, I mean, it's correct that, so prednisolone, of course, is the active metabolite of prednisone. And so the liver has to convert prednisone to prednisolone. And so often in cases of severe jaundice and very high liver tests, we do use prednisolone, with alcoholic hepatitis kind of being the most common scenario that we use that in. To be honest, I use prednisone a lot and it works just fine. So I don't think we have good data to say that prednisolone is better than prednisone outside of the setting of, just prednisolone being recommended for alcoholic hepatitis. So I use prednisone and it is always fine. It's also much cheaper for the patient. Prednisolone can be quite expensive.
Yeah, in our case, she was put on methylpred 40 milligrams IV BID in the hospital and discharged on prednisone 20 milligrams BID.
Yeah, other good points about, when you see someone like this, especially when they have coagulopathy and there's concern that they could be progressing to ALF, there are patients that will have their very first presentation of autoimmune hepatitis as acute liver failure. And those patients sometimes have already developed cirrhosis, but not always. And they can be very severe. And so, recommendations are always, you want to try to salvage that liver if you can. And so recommendations are always to try steroids first. But really going above prednisone 40 is not recommended. And guidelines say that if after 2 weeks the patient hasn't improved, you should just move forward with liver transplant listing and not subject them to any further immunosuppression, because the likelihood is that they're just going to have significant side effects like infections in the setting of already being very ill, and it would be better just to take them off of treatment and transplant them as opposed to, increasing steroids more and more and more. But great case. It's always fun when we can identify the culprit agent. We can't always do that. Have you guys seen a lot of drug-induced liver injuries or drug-induced autoimmune hepatitis, or is this the first one?
This was my first case. I've seen drug-induced liver injuries, but this is the first time I saw a drug-induced autoimmune hepatitis. I didn't know it was a thing before this.
Mhm.
Yeah, I think it's a great case. And, other drug-induced liver injuries that we see, especially things like augmentin, when they're really jaundiced like this, we'll tell patients to expect it to take up to 6 months for the jaundice to completely resolve. So it can be a very, very slow recovery process. But things like this, when we were able to give them steroids, they actually resolve fairly quickly. And I would guess that probably within a month or so, this female wasn't jaundiced anymore. So that's always nice to be able to offer patients a quick solution. I do, I think probably all of the hepatologists do things slightly differently, but there are sometimes patients who will have this pattern of liver enzyme elevation that won't have a serologic workup or biopsy that's consistent with autoimmune hepatitis, and they may have a lot of inflammation on biopsy, but not necessarily consistent with autoimmune disease. And I generally still give that patient steroids. When there's just so much inflammation and necrosis, it often does help. And we've had several patients with sort of an unidentified suspected drug-induced liver injury that have responded really nicely to steroids. So I think as long as they're being monitored closely and with weekly outpatient labs, that can be a safe option.
Can this develop into vanishing bile duct syndrome, or is that something that kind of primarily occurs, or does that the vanishing bile duct syndrome occur after a drug-induced injury or something like that?
Yeah, there's a very broad differential for vanishing bile duct syndrome. Generally, things like this would not progress to that. This patient should completely recover. There's a chance that she might lay down a little bit of scar tissue just with all of the necrosis that she had with liver tests this high. But the liver has such an amazing ability to regenerate that if she developed any scarring at all, I would think maybe just stage 1. But in terms of vanishing bile duct syndrome, the differential is so incredibly broad, but really it's a destruction of the intrahepatic small bile ducts. And so that can be, drugs can cause that, and that would predominantly present with a very high elevated alkaline phosphatase level. But other, malignancies can cause it. The case we had was lymphoma, and it can present as a paraneoplastic syndrome related to lymphoma. But there's just a very broad differential of different diseases and medications that can cause that. So it generally doesn't, I wouldn't say it starts as one thing and progresses into that. It generally starts as that from the cases I've seen. But yeah, we actually, I think one of the residents will be, well, I guess publishing the case that we had a patient that had liver tests not dissimilar from this, from a paraneoplastic syndrome related to B-cell lymphoma. And she actually completed her treatment, and she's about a year in remission now. And finally, all of her liver tests are completely back to normal. But, she did have a biopsy consistent with vanishing bile duct syndrome at the time when she was jaundiced. And so we always worry that once you've lost those bile ducts, that the jaundice won't resolve, and that a lot of those cases ended up progressing to liver failure. But she did very well and did nicely with chemotherapy, and her liver's completely back to normal now, which is awesome.
Awesome. Well, thank you so much, Dr. Gray, for being here tonight. Anybody else have any final questions to ask Dr. Gray before we head out? Thank you, Mahmood, for presenting this great case. Definitely learned a lot. Natasha for scribing, Dr. Centaur for being here always. And thank you all for being here. Any final questions, comments?
No, I think that's a